Sonaji, you can just give the count.
Good evening all. Welcome to this edition of the Frontiers in Liver Disease 2020. This is virtual like all of the meetings this year. We are honored to have a very distinguished panel today. We're very excited to bring you these three talks by three of the best thinkers in HPB surgery and liver transplantation. The first talk today is by Professor Darius Mirza, who will be talking about the outcomes of liver transplantation in infants with liver failure, followed by Dr. James Fung, who will talk about precision medicine and hepatitis B. And then, of course, Dr. Joy Varghese will give his insights on liver transplant for acute and chronic liver failure, which is always a topic that arouses a lot of interest and discussion. So without further ado, I'd like to introduce Professor Darius Mirza, who is giving the first talk, who is a consultant HPB and liver transplant surgeon. He needs no introduction to all of those of us who work and practice in any sort of liver disease and transplantation. He currently practices at the Queen Elizabeth Hospital in Birmingham, which is the largest transplant center in Europe, as well as in Apollo, Navi Mumbai, where he has helped to set up a transplant which has promoted affordable liver transplant for children in India. So that is sort of one of his many accomplishments, but since time is limited, I'm going to leave it there and hand it over to him. Professor Mirza.
Thank you, Sonal. I'll just try to screen share. Thank you very much, everyone, for the very kind invitation. Sonal, thank you in particular. And thank you for bringing this up as a topic, because it forced us to do something that we've been meaning to do for years, which is update our numbers of the little fulminants. So I know you've got a bit of science fiction coming up and some other science and some precision work, so I'll just put this in. So the timing is quite good. I put this in as one of those frontiers that many liver transplant surgeons want to aspire to. They're always wary about the really little kid. And if I have a 2-week-old waiting for a transplant and I have to do it the next day, that's the one transplant now that still keeps me quite anxious the night before. So we do our kids at the Birmingham Children's Hospital. We're what we call a high volume unit, doing about 40-45 kids a year. That's out of a total of about 250 to 270 grafts a year. I think this year's numbers will be less. We used to function at a very old hospital at Ladywood. That's where the program got going, and we're functioning now at an even older hospital because the Ladywood Hospital site has closed down. So we took over the general hospital. And the program got going through the 80s. We learned a lot through the late 80s and the early 90s. And then we were fortunate at that time to be right at the cusp of the developments of reduced size liver transplantation, split liver transplantation, intestinal transplantation. And we did the odd fulminant. But it wasn't until the late 90s that we would take on the really small fulminants. So I'm going to focus on mainly the last 20 years. Once you do a trawl through the literature, you find that there's quite a bit in terms of guidelines and the groups of patients, but there's not too much in terms of outcomes. Everyone just says that the outcomes are slightly inferior compared to what you see with acute liver failure in older children. So what is acute liver failure in little children? So I think the key couple of things are with or without prior liver disease, a coagulopathy, high levels of PT-INR, and the key thing is in a child that small, often understanding encephalopathy and eliciting it is almost impossible. So with or without associated encephalopathy. So that's transplantation is the only treatment available. There are lots of challenges, and we'll spend the next 10-15 minutes talking through these. Whatever's there in the results show that they're a good 10 to 20 points inferior to what we see with transplantation for children in general. And then there are key issues with respect to selection. Time won't permit me to do too much of that, but it's very important not to do futile or pointless transplantation. And the role of the pediatric hepatologist to exclude some metabolic conditions and to exclude treatable metabolic conditions are very important. So you're left with these following conditions that land up presenting with acute liver failure that require patients to be considered for transplantation. So some metabolic conditions, seronegative hepatitis or indeterminate hepatitis, herpes simplex virus as something. I want to talk about that because we now consider that as a contraindication, especially if there is multi-organ failure. And then the bread and butter is largely going to be neonatal hemochromatosis, and then a whole list of others like eosinophilic or giant cell hepatitis. So what are the big challenges? So that isn't a big hand of an anesthetist. That's an average-sized anesthetist's hand. And that's about as small as we have gone. That's the kid who is just around 2.1 kilos with quite a bit of ascites over there. We know that age represents a very relative negative predictive factor, and that's at both extremes of age. So at this extreme of age with the condition, it's a key factor. Making the diagnosis, I already mentioned earlier, is crucial to prevent futile transplantation. And then from the team, once they made a decision about transplantation, there are a few important points to understand. The incidence of this disease is very low, so the frequency is low even at a high volume center. There's big issues with patient size. There's big issues with graft and recipient weight mismatch. Obviously, huge issues with graft availability, even if you've got a situation where you can fast track living-related donors, because if the kid is very small, one of the two parents is potentially not a donor. The mother's usually not a donor in that setting. There's issues about vessel size, mainly about the artery and the portal vein. There's issues about the abdominal domain. And then two very important areas that have come on in leaps and bounds in the last 20 odd years, which is why the results are better now. The ability of our skilled anesthetists to be able to take very small babies through this operation. And then pediatric ICUs to be able to manage these kids pre-transplant. And then even the 2, 3, 4 weeks that some of them spend on the intensive care unit afterwards. Filtering a 2.5 kilo baby with renal impairment and metabolic acidosis is not the easiest. Likewise, ventilating someone for 2 weeks while a big, huge graft settles in is also not the easiest. And as a consequence, there are very few papers on outcomes. This is our donor pool. This just looks at age, and it just tells you, less than 5% of our donors are under the age of 17 years. So you have to innovate, and you have to innovate beyond what you would innovate for bigger kids. So a few surgical aspects. Some of it is practice. Some of it is what I have learned not to do. So I will assess the artery quite early. So the neonatal hemochromatotic liver, so that's the one on right up there, is essentially a cirrhotic liver. Will often have a good, well-developed artery and a not too bad sized portal vein. You hardly ever see portal vein hypoplasia in this group of patients. And you could consider using the native artery, where we've got a very low threshold to put an aortic implant in, an aortic conduit in. And we put that conduit in right early on, before the hepatectomy, just to keep the anhepatic period as short as possible, and also have to have the vessels absolutely ready for when the graft is implanted. I think it's very important that the hepatectomy is as bloodless as possible. A kid of 2.5, 3, 4 kilos does not tolerate 50 cc, 60 cc, 70 cc blood loss. We don't fiddle around too much dissecting it off the vena cava. We just put bicable clamps, cut it out. The kids tolerate the vena cava clamping very well, and you don't want to run the risk of losing blood from a very tiny hepatic vein, during a tedious dissection. It also keeps the hepatectomy phase very short. So within 35, 40, 50 minutes, usually the liver is easily out and ready for implantation. In terms of the implantation, big wide confluence of the hepatic veins, we use absorbable stitches. It's all pretty fine stuff, 5-0, 6-0, sometimes even 7-0. And we are very particular about pre-closure Dopplers just to make sure there is no compression on the vena cava. It's the easiest thing to compress a tiny baby's vena cava. The picture on the right is another one of our children, one of our first ones about 20 odd years ago, and that's his tiny little liver, 25, 30 grams at the age of 14 days, and he weighed, I think, 2.5 kilos at the time of his transplant. In terms of implantation, it's not very different compared to the left lateral implant. I think the key thing is just a very wide, triangulated venous outflow. And with a split graft, like in a living related graft, you get a nice short hepatic vein. So the chances of it flopping over or kinking are very, very low. As far as the portal vein is concerned, it's not as bad as some of the very small biliary artritics. You almost always will get a portal vein. Sometimes you have to get down to the junction to put in an interposition graft. Essentially, the use of interposition grafts in this group of patients you think would be high, but it's actually not so high. And then again, we're quite careful about ensuring that there is some reasonable portal venous flow at the end. We try to keep the portal vein clamp time as short as possible because these guts get very edematous once you clamp the portal vein, unlike a biliary atresia patient. We also know that the smaller you go, the higher the incidence of post-operative portal vein complications. And here's just 3 series, a large US series, something from Mureo Kasahara, and something from our colleagues at King's College Hospital. And you can all 3 of them say the smaller you go, under 5 years in the US UNOS study, King's also the very small group and Mureo's group have a much higher incidence of portal venous problems in the very small children. In terms of the artery, I talked a little bit earlier on about the placement of the conduit. Again, the conduit usually comes from donors. The donors are usually young adults. And I think you've got to be very careful what vessel you use, because invariably the recipient aorta will be 3 millimeters, maybe 4 millimeters. And then the conduit vessel is at least that size, if not bigger. So it does have implications on flow patterns after the transplant. If you do have a good enough recipient artery, as you may get in some patients with neonatal hemochromatosis, then you're better off using it. If the arteries are good, we just use exactly the same technique. We don't resort to using any microscopes. We just use loupes and a conventional microsurgical set. They will all get a roux loop, because even if the duct is usable, the risks of complications are quite high. And also the ability to get into a small neonate's duct if you ran into trouble post-transplant is very, very difficult. So a key area is the mismatch, size mismatch, and almost always these children will get livers that are effectively a large size graft. So I think we're averaging somewhere around 3.5% to 4% as the GRWR in this group. And then you have 3 or 4 options over here. The commonest option is to use an abdominal wall prosthesis, and we use Permacoil here. We will subsegmentally reduce if we can and if we have to, and we'd use something like the Kasahara monosegment 2 graft, very infrequent. And then another approach is to tide over the first 4, 5, 6 days with a silastic patch and delay the abdominal closures. So all these tools are crucial in terms of taking some of these kids through. The shape of the liver is also hugely important, and I've just highlighted, something that Murray always puts up. It's the shape of the left lateral segment is crucial. The smaller the child is. So you want a nice, flat, slim left lateral segment that you'd get from a nice 50 kilo slim female donor, rather than going for a 65, 70 kilo male donor who's a bit chunky from anterior to posterior. So the shape is hugely important of the graft and decides whether you want to consider doing a hyperreduction or not. So as I said, Sonal forced us to do this audit. So you're going to be inflicted with this audit now. It's been done by Chaya Calgary, who some of you may remember from her days at Global Hospital. And Kej Bici is one of our Italian surgical fellows who's prepared this. So it's literally hot off the press, and thank you again. So 220 odd acute liver failures, of which about half were under the age of 1 year, and only a relatively small proportion of these were transplanted, which again shows you there's a huge amount of selection there. And there's also quite a bit of patients that don't make it till a suitable donor organ becomes available. In terms of the diagnosis, the indeterminate group is the largest group. This is what we would also call seronegative. There's a few selected metabolics here: neonatal hemochromatosis, herpes simplex virus for 3 of these patients. And the presentation is pretty standard. Lots of ascites, almost everybody with jaundice, and a few presenting with sepsis as the index event. Looking at some pre-transplant variables, a median bilirubin around 300, which translates to about 18 or 19 in milligrams percent. Big transaminase levels, biggish ammonia levels, not so high creatinine levels as you would expect in a pediatric population, and with a PT that goes up as high as documented there, up to 180. Of these, approximately 45%, so approximately half were admitted to the intensive care unit pre-transplant, approximately a third ventilated before the transplant, and approximately a fifth or a sixth needing hemofiltration for fluid and acidosis management pre-transplant. So a very, very unique select group. So this is our experience over the last 20 years. The blue is the age, and the browns are the weights. And you can see there's probably a slight tendency to taking on slightly higher weight children as we have evolved. As I said, even on a busy unit like ours, we'll have one case every 10 or 12 months, and we'll be lucky if we do 3 over a 2-year period. A bit more on these patients who are transplanted. Median weight around 4 kilos, median age at transplantation 44 days. Good, nice long-term follow-up. A higher rate of graft loss, and this is long-term graft loss because there's a few chronic rejections there as well. And overall, we've lost over this time period 10 patients, 7 in the early period in the first 10 years, 7 in the early period of post-transplant within a 3-month period, and 3 late deaths. So let's look at some transplant variables, and the surgeons understand this language quite well. So a median weight around 4 kilos, a median donor weight around 50 kilos, giving us a donor-recipient weight ratio of around 9 to 10. So big jump over there. Looking at graft recipient weight ratios, you can see the means around 6 and the medians around 5.7. So very different compared to what you would accept for other children. You have to be very wary about the large for size graft situation. How high can you go? We've gone up to 22, as you can see, in terms of a graft recipient weight ratio, and in terms of donor weight, up to 16 times the difference between the donor weight and the recipient weight. Technical numbers: large use of arterial conduits, very few portal venous conduits, conventional left hepatic vein to confluence for the IVC. There's a few that were cable replacements, and these were 2 or 3 very small donors that were implanted. And then universally, the use of a rule loop almost always there. Higher incidence, again, numbers are quite small, only 30 patients. But if you just look at that, redoing the portal vein 3 out of 30 times, redoing the artery 2 out of 30 times. So not insignificant. So definitely looks slightly more challenging than you would get with your larger pediatric patient. The same thing is reflected also with early post-operative complications. Have listed the surgical ones here, the vascular ones, the biliary ones, and others. And you can see there's a few that are unique to this population. The compartment syndrome group, the development of collections, because each collection, even a 5 centimeter, 8 centimeter collection, is significant and will affect weaning and ventilation and recovery and the ability to close the abdomen. And then there's the odd bowel perforation. The good news is that these patients have not had previous surgeries, so you don't have to deal with the problem of making enterotomies because of the previous Kasai operation. Closure, as you can see, primary closure only in 1/3 of the patients. Secondary closure in 2/3 of the patients, and then if you have a stage closure, you've got more issues in terms of impacting the stay. The bigger the discrepancy between the donor weight and the recipient weight, the more likely you are to have a staged abdominal closure. Other complications, it's important to put these 2 in. So I think the primary non-function we can probably leave out, because often it's a very sick recipient, because these patients almost always get very good livers. But one would have thought that this population would not get much by way of acute rejection, quite high over there, and then quite a high incidence of chronic rejection. These are obviously patients that are followed up into the long term. and quite a high incidence of bacterial and viral problems afterwards. At this age, again, they are much more prone to post-operative opportunistic viral infections that you would not see in slightly older children. Just a few tables now, just with the simple take-home messages. So 3 out of 3 HSVs died. So we now consider that a contraindication. So if you've got multi-organ failure, we will not take on herpes simplex virus. Pre-existing sepsis came up as a significant factor in the risk of mortality afterwards. And then one or two other factors played a role in mortality. The need for renal support, which again, you'd expect to mirror image what comes up with, in an adult pool or in an older pediatric pool. And then the higher the PT was higher at the time of listing in the ones with the worst outcome compared to the others. Talked a bit about chronic rejection earlier on. I think difficult to say too much about it, given that many of these patients develop these problems several years out, and there are other issues related to adolescence and compliance and puberty. So I think it's difficult to read too much into this. What's good is you can go against blood groups, and obviously which provides you a complete mix of patients, identical, compatible, and incompatible. We don't change immunosuppression protocols at all, and you can see there's no difference in the 3 groups, whether it was identical, compatible, or incompatible in terms of blood groups. Some logistic regression, again, busy slides, but just to show you that's all been put through a system. So the patient weight comes up as something. The donor age comes up as something, and it's interesting, whenever you do any analysis, donor age always comes up as something. In terms of graft loss, whether you developed a portal vein thrombosis post-op had a problem, a biliary complication had a problem, and those who developed late chronic rejection also had a problem. In terms of predicting death, really nothing much came up in terms of the variables, with all the limitations of this being a very small patient and selected patient cohort. Similarly, also with other factors and the development of complications, not much of an impact in terms of being able to predict death. So if you look at Kaplan-Meier curves, so the curve on the left looks at all comers. You can see patient survival at 1 year is 76%, and of those that have survived, 87 have survived with their index graft. Okay, 5-year survival, not very different. Overall patient survival is out there. The curve on the right looks at 2 groups of patients, this is the very small neonate, and then also the larger child up to 12 months, and this has excluded the 3 herpes simplex patients. And then these curves really don't look very different to what you achieve with acute liver failure in older children. And this is what we are seeing nationally with all comers undergoing elective pediatric transplantation. So not very different compared to what is your bread and butter of pediatric liver transplantation. So please forgive me if you've already seen this set, but this young man is a good friend of mine. He's a Christmas special of 20 years ago. I think we had no other surgeons in town, and the decision of whether one goes ahead with him or not. Both he and his mum were admitted with acute liver failure with giant cell hepatitis. Mother's liver managed to recover. He got a cadaver liver. He was 2.5 kilos. He was the smallest kid we did then. We've dropped down to, I think, 2.1 kilos since. He did exceedingly well, and then developed chronic rejection following a viral illness at the age of 13 or 14. He tried to keep that graft going, required a retransplant, got a retransplant from a living-related graft. That graft failed because of small for size, interestingly, because he had quite significant portal hypertension, and the donor was an older male donor. And then he got a cadaveric graft from a very small, full-size pediatric donor. So this young man is now 20 years out. We play an annual cricket match against him, and they've raised a huge amount of money for the liver unit. And right now, the last 4 years, these boys keep getting bigger and bigger, and they've thrashed the living daylights out of us. So in summary, I think it's a subgroup that's very interesting. Timely recognition of the condition and early referral is important. And this is a message that has to go out to community midwives, etc., in a kid that is floppy and not doing well post-delivery. Selection is vital. It's important to prevent futile transplantation, and I think time has not permitted me to go too much into that. We can discuss that. The listing criteria are different, so please be patient if another center lists a very small baby and does not tick your boxes that you understand as the King's College criteria for your adult patient or your teenagers. It's important not to do the patients who have significant contraindication, the mitochondrial disorders, and we would consider herpes simplex and multisystem involvement as an issue. Innovation is essential. Big technical aspects that we've covered: vascular, small for size, delayed closure, and hyperreduction. Graft selection has to be very careful because the margin for error is small. And then there are two groups of people that have really facilitated this, and I consider them the real heroes. So the pediatric anesthetists and the intensive care teams. The ability and the courage to take on a 2.5 kilo baby, manage them for 4, 5, 6, 7 days, and then for the 3, 4 weeks afterwards, some of them with filtration, with the big fluid shifts, is quite astounding, and that's the big difference compared to 20, 25 years ago. Higher incidence of early problems, so much more vigilance required, and the outcomes still are slightly inferior to what you see with pediatric transplantation. But the long-term outlook is fantastic with the Kaplan-Meier curves all flattening out. I couldn't find a picture of all our fulminant kids because we never collected them, the small kids. But this is a group of our multivisceral recipients. So these are intestine transplant recipients. And the picture on the right shows the parents of these kids, and they are the real heroes. If I have 1 minute, I just want to promote our foundation. It's based in Mumbai. Sonal knows pretty much well about it. It's called Transplants Help the Poor Foundation. And we're happy to help patients requiring financial support for transplantation at any registered Indian pediatric or adult liver transplant center. Thanks a lot, guys.
Thank you, Professor Mirza, for that excellent overview. While we wait for questions to come on, there's one question on the chat from Patek Parekh. It asks for a subgroup analysis of data on patients transplanted before and after 6 months of age.
So the numbers are can you still hear me?
Yeah.
The numbers are still too small to be able to look, but there definitely is an advantage if you pass the 5 kilo mark. Definitely. So, and I think any surgeon would understand that it's a completely different, it's a complete tiger country if you're under the 5 kilo mark. And under 3 kilos, it really becomes almost a lottery, if you know what I mean.
So I had a couple of questions with regards to technical aspects. Obviously, we've been guided a lot by your work, the work coming out of King's and from Professor Kasahara's group in the technique that we use. And are the techniques relatively comparable for, say, an acute liver failure versus a cirrhotic? Because in my mind, if you have an acute liver failure, there's not a lot you can do to augment portal outflow. It is what it is, because we do sort of patching of the anterior portal wall, for example. We tie up the coronary vein and we do the mobilization of the right and the left hepatic flexures, but the hepatic flexure and the splenic flexure. But there isn't much more we can do, right, in terms of augmentation, or is there?
No, literally almost nothing. But I think the key thing is, compared to the biliary atresia, you can always preserve the portal vein confluence. And the trick is to take it as wide as possible and produce the best possible funnel between the recipient portal vein bifurcation patch and what you've got with your donor liver. You can't influence the diameter of your donor left portal vein. That is anywhere between 8 millimeters and 12 millimeters, depending on the size of the graft. Because you select out relatively smaller grafts, you might be fortunate to get 8 or 9 millimeters. And you'll always be able to take the patch from the recipient from 3 millimeter, 4 millimeter diameter portal vein to a patch size of 6, 7, 8 millimeters. Always, almost always. And then no kink. I think they don't tolerate kinks well. And I would keep the portal vein clamp time as short as possible. And then lastly, in these small babies, I do not use a vascular clamp for the portal vein. I use the softest, tiniest, most gentle little bulldog that I've got.
Okay. No, that's great, because that's helpful. We also, the incidence of vascular injury with any of our stiffer even bulldogs is actually quite high. So that's
soft. Venus spring bulldog is the best one.
Sonal, can I ask a question?
Sure.
Hi, Professor Darius. This is Matthew here. I'm a colleague of Sonal. Great talk. Obviously, this is an area which is quite challenging, and it's great to see the results as well. Could you just explain a bit more about the GRWR? And if I heard correct, you mentioned you went up as 22. Could you just expand on that?
So the GRWR in terms of what the weight of the left lateral would be. These grafts are then hyper reduced, but you're looking. I can't remember the exact figures, but you're looking at figures that are well above what you would normally accept. 6-7% is literally the norm. 7%, and you don't need much. A 200-gram liver will occlude the flow of a 4 millimeter IVC, even if there's the tiniest amount of pressure closing the abdominal cavity. And we've all made that mistake. So the mistake has been as recently as 4-5 years ago. So the threshold to close should be very, very different, because even the tiniest amount of the graft sitting on the cava can affect the outflow. And that just sets up a whole set of hemodynamics that you have no control over.
Okay. So you mean you had a larger GWR, but you then cut them down? Is that what you're saying?
Yes, we would trim them down. Yeah.
Okay, fine. Thank you.
The other question, intriguing here about your data was that a lot of your patients were on hemofiltration, which sort of adds to the complexity a lot, isn't it? I mean, did you do any correlation between say vascular events and people who were on hemofiltration?
No. So these kids usually it tends to be very short. It tends to be to tide over the period of acidosis or extremis that leads them to go to the ICU. We tend not to use any anticoagulation in these patients preoperatively. And then post-operatively, we're always very wary about this group of patients. Anybody who's on a filter has a much higher risk of a bleeding diathesis. It's not so much thrombosis; it's more a bleeding diathesis that you're worried about.
And lastly, just one last question is in terms of preference, do you have a preference between a monosegment or a reduced left lateral? What's your preference?
I think the reduced left lateral treats more the surgeon than the patient.
Yeah.
So I think if you really were to do a reduction because you can't fit something in, you're better off going it down to a monosegment. It does add an additional component to it because it's a double resection. So essentially, I think if you're fortunate with a left lateral segment, you can trim a little bit off the lower part and a little bit off the lateral part, but it doesn't add much. It doesn't add a huge amount. It doesn't change the chunkiness. You get one of those little mini burgers. That's what you want. What you want is a slim mini burger rather than a fat mini burger. And if the mini burger is fat, I think trimming it doesn't make. The only advantage of trimming it down further is you probably don't have the problem of underperfusion of the periphery of the graft. Because remember, they don't have a huge portal venous flow, and the graft they get will always be 3 times, 4 times, 5 times the size of the native liver. So perfusing these grafts is also not easy. Hence the advantage of having a nice aortic conduit for the arterial inflow.
Sure. Thank you so much for that, Professor Mirza. My apologies to the non-surgical colleagues for sort of a very deep dive in the surgical technique, which probably weren't prepared for this evening. Thanks a lot, Professor Mirza.
Yeah, thank you.
It's now my pleasure to introduce Dr. James Fung, who is a consultant and clinical associate professor at the Department of Medicine and Transplant Hepatology at the Queen Mary Hospital, Hong Kong. Dr. Fung has done his training in Auckland and has been a transplant hepatologist at Hong Kong. He's going to talk to us today about precision medicine and hepatitis B. Are we in sight of a cure?
Thank you very much for your kind introduction. Let me try and share my screen and let me know if you can see it. Hang on a second. Can you all see the screen? Hang on. Is the screen of...
Yes, it is visible. It's visible.
It's visible. Okay, fantastic. All right, so let's get started. So thank you again, and also thank you to the organizing committee for allowing me to speak on this topic. Let me see if I can actually advance the slide back. Good. And thank you to the organizing committee for the opportunity to speak at this wonderful series on frontiers in liver disease. I would have loved to have visited your country again, and hopefully we'll be able to do so once this pandemic is over. So my topic this evening is on hepatitis B, and it's a topic which I hold dear to my heart. So despite oral antiviral therapy being available for over 2 decades now, and we're seeing a decline in chronic hepatitis B as a primary liver disease indication for liver transplant. And you can see on this black line here a steady but significant decline over the years since antiviral therapy has been available. And however, it still is remaining the most common primary liver disease for liver transplantation in many parts of the world, including Asia and including Hong Kong, where I live. We are seeing more of older age patients as indicated by this blue line here, and we're seeing less decompensated cirrhotics, the red line here. And however, we are seeing an increasing cases of hepatocellular carcinoma. And although liver transplantation is curative for cirrhosis, liver failure, and hepatocellular carcinoma, remember it is not a cure for chronic hepatitis B infection. The hepatitis B virus can still reside in the extrahepatic sites, and hence lifelong antiviral prophylaxis is still required to prevent reactivation. Now, there's been many debates and studies looking at the efficacy of different antiviral regimes, and the results have all been somewhat conflicting. And I think this is largely due to the limitations in the definition of hepatitis B recurrence after transplantation. But you have to remember that a negative hepatitis B surface antigen does not equate to eradication of the hepatitis B in a patient that has been chronically infected. And if you turn it around, that means that a positive surface antigen after transplantation does not actually mean recurrence of a hepatitis B infection. In fact, the patient is already chronically infected and has never been cured in the first place. However, most studies have based their outcomes on recurrence based on the surface antigen status, whereas one must also remember that long-term graft and overall survival still remains the most important clinical endpoint. Now, this slide shows you all the current available antiviral regimens in use by different liver transplant centers, and all the different permutations that's possible is on the right side. And there's currently no general consensus as to which regimen one should adopt. And also for those using HBIG, what dose you should be using, the duration, and also the target antibody levels that you should be aiming for to be so-called protective. It is likely that the regimen used at each of these individual centers is actually based on historical protocols, which has been evolved upon, and also the cost and also the availability of each of the agents. And you can see that, in fact, the blue part, you can see that the regimen is actually built upon the essential backbone of nucleoside and nucleotide analogs made up of entecavir, tenofovir, or both together with a different HBIG approach ranging from long-term use, limited duration, perioperative use, and to using no HBIG at all. And although one can argue about which regimen is superior, I can totally assure you that all of these regimens are in fact highly effective. Now, some clinicians may be very apprehensive about not using HBIG at all because the protocols they have been using have always incorporated HBIG and they're a bit reluctant to see this go. In fact, the Queen Mary Hospital at our center, liver transplant center, we've always adopted the completely HBIG-free protocol and approach, whereby we don't use any HBIG preoperatively, we don't use any perioperatively, and we don't use any post-operatively. So we don't actually use any HPIC at all in our transplant for chronic hepatitis B. Back in the days of lamivudine, back in the late 90s, the disadvantage, of course, is with the high resistance rate with subsequent virological rebound. Therefore, it is not surprising that HPIC actually at that time was widely used at this point worldwide, because lamivudine monotherapy has been associated with increased risk of resistance and virological rebound. Unfortunately, not long after, adefovir became available and was effective for those who developed resistance and was used in combination with lamivudine. Nowadays, we have highly potent antiviral drugs such as entecavir and tenofovir with minimal risk of resistance, and therefore the use of HPIC, I think, has become much more questionable than when we were using these newer agents. And over the next few slides, I will present to you the data on outcome of chronic hepatitis B patients who have undergone liver transplantation and received a completely HPIC-free regimen for antiviral prophylaxis. When you're using a nucleoside-nucleotide analog-only approach, you can see that even without using any HPIC at all, the majority, in fact, will undergo surface antigen seroclearance. But we also know that this doesn't mean that the patients are cured from hepatitis B, and therefore long-term prophylaxis is still essential to prevent reactivation. So again, if the patient remains surface antigen positive after transplant, it doesn't mean that they have a recurrence. As liver transplantation, as I alluded to you before, doesn't cure the infection. When we actually do quantification of the surface antigen after transplant for those who are surface antigen positive, you can see that the surface antigen levels are in fact at very extremely low levels. And because a lot of our patients present with severe acute flares, a lot of these patients actually go into transplantation with a high viral load at the time of surgery. And in fact, if you can see, only about a quarter of the patients who underwent transplant had undetectable HBV DNA at the time of surgery. And despite this, most of these patients will have surface antigen seroclearance, and almost all will have complete viral suppression after liver transplantation. And when we look at the long-term outcomes, we can see that the surface antigen seroclearance is sustainable out at 8 years, over 90%. And if you look at HBV DNA suppression, again, it is durable. We're talking at 100% at 8 years after liver transplantation. And of course, the most important clinical outcome is the long-term survival of patients after transplant. And on the right side, you can see that the overall survival of these patients were 85% after 9 years after transplant for hepatitis B, without any deaths related to hepatitis B reactivation when using a completely HPIC-free regimen with entecavir alone. And I can assure you that if we did use HPIC in these patients, giving HPIC would not have improved their survival in any way whatsoever. Now, there's always a concern that a higher number of patients will remain surface antigen positive after transplant if we don't use HPIC. An argument that it is therefore less effective because more patients are surface antigen positive if you don't give HPIC. And I've already explained to you about 2 points. One is that surface antigen positivity does not mean Hep B recurrence. And secondly, even if it is positive, it is at a very low level when you measure it quantitatively. Now, if we give these surface antigen positive patients HPIC, of course, it will bind onto the surface antigen, form complexes, and therefore it will render it undetectable. But it is unlikely that this will translate to any clinically meaningful benefit. When we biopsied our surface antigen positive patients, we do not see any positive staining in the liver for surface antigen, and indeed there was no histological evidence of hepatitis B related graft hepatitis. All of these patients remain HBV DNA negative. And furthermore, when we look at the liver stiffness of all our patients after transplant, we did not find any difference in liver stiffness between those who were surface antigen negative and between those who were surface antigen positive. However, unfortunately, a lot of studies, I think, still, including the meta-analysis and also systemic reviews, have included older drugs such as lamivudine, which, as you can see, is associated with a significantly higher rate of virological rebound due to the resistance development. And I think, therefore, the most important aspect of using oral antiviral therapy when you're using it after transplant is to use one with high barrier to resistance. And really, there's only 2 choices that you should be using, which is entecavir or a tenofovir-based treatment. But even for those with pre-existing drug resistance, an HPIC-free regimen using newer oral antiviral agents is still highly effective and also associated with very excellent long-term outcome, as you can see here. When we look back at our patients who had lamivudine resistance at the time of transplant, using a completely HPEG-free regimen was still associated with an excellent long-term outcome at 85% at 11 years. So with time, we have observed a shift in paradigm shift from using a very high dose of HPEG to low dose intravenously, then intramuscularly, and then talking about limited duration HPEG withdrawal after a duration of period of therapy, and then to a completely HPEG-free approach. And a trend towards using less HPEG really stems from the fact that it is more costly, and the patients are required to come back for regular injections to top up to an arbitrary protective antibody titer. And of course, this shift towards using less and less HPEG is only made possible with the availability of these highly more potent antiviral therapy with minimal risk of resistance. So far, we can see that the current existing prophylactic strategies are highly effective in suppressing hepatitis B and preventing reactivation, and also with preventing graft hepatitis. And this all results in excellent long-term survival, as I've shown. However, the current oral antiviral therapy is still ineffective in eradicating hepatitis B completely, and hence lifelong therapy is still required. So in short, hepatitis B still cannot be cured with the current available nucleoside and nucleotide analogs. Which brings me into this diagram, which shows you the cascade of cure. And this ranges from viral suppression, where the viral replication is suppressed, to partial cure, whereby patients can actually stop the antiviral therapy, for instance, after e-antigen seroconversion, but will still have low-level viral replication, to functional cure with surface antigen seroclearance, but still with viral cccDNA and integrated DNA, down to complete cure with clearance of the cccDNA, but still with the presence of integrated viral DNA, and finally what we call a sterilizing cure with elimination of all viral particles. Now, the current existing antiviral therapy that we have is highly effective in viral suppression. Most of our patients on antiviral therapy will have undetectable HBV DNA after a certain level of therapy. However, it is not very effective in inducing a partial cure, and rarely effective in inducing a functional cure with loss of surface antigen. The rate of surface antigen seroclearance is probably closer to 1 to 2% per year for patients on antiviral therapy. And one of the reasons why our nucleoside and nucleotide analog is only able to control replication but not cure is because it only acts on the downstream site in the hepatitis B replication cycle over here. Now, the highly stable viral particles inside the nucleus, the cccDNA, and continues to serve as a reservoir of infection and a template for viral protein synthesis. And from the replication cycle, you can see that, in fact, there are many potential targets for antiviral agents to act on, starting from viral entry to cccDNA expression, transcription and translation of viral proteins, packaging of the viruses, down to the release of the virus. And also, don't forget also about modulating the host immune pressure in trying to control the long-term viral replication. So I will go through some of the targets and the available data, starting off with viral entry. And this diagram shows you that the virus enters the hepatocyte via the NTCP receptor. And the most studied agent to inhibit hepatitis B virus entry is a compound called mercurydex. This is a synthetic lipopeptide which blocks attachment of viral pre-1 S1 protein onto the receptor by competitively binding onto NTCP, blocking the entry of hepatitis B, and also it blocks hepatitis delta virus. Although it appears not to have much effect on reducing surface antigen and also hepatitis B DNA, it was shown to reduce hepatitis delta RNA significantly. And I think this may actually be an important treatment option for patients with delta virus co-infection in the future. Interestingly, for liver transplants, for the field of liver transplantation, cyclosporin and its analogs have also been shown to have some effect in the NTCP receptor, and thereby can also reduce to a degree the entry of hepatitis B and hepatitis D virus. Another potential target is the targeting the transcription and translation of viral proteins through the use of what we call RNA interference, or RNAi. And by reducing the viral protein production and also the viral antigens, it may be possible to reverse the immunoparesis that can be observed with high viral antigen loads. The hepatitis B RNA, as you can see here, has 4 transcripts which overlap. So you can actually design a drug to target these overlapping sequences. And these drugs are either siRNAs, small interfering RNA, or ASO, what we call antisense oligonucleotides. And what they do is they bind onto the target RNA, and once bound, they can promote RNA degradation. You can see more clearly on the next slide, these siRNAs are actually very small, highly negatively charged, hydrophobic, double-stranded oligonucleotides, which mean they actually need a highly effective delivery system to enter the liver cells and protect it from nucleolytic enzymes as such. So they also need parenteral administration, as it is rapidly digested within the GI tract. So one is a peptide carrier, and another example is a lipid-based carrier system, delivery system. So as you can see, once inside the hepatocyte, the siRNA is then loaded into the RISC complex, which is the RNA-induced silencing complex. And then the passenger strand is removed, and so now it can target the specific viral mRNA strands, leading to cleavage and then subsequent degradation of the viral mRNA. And one such compound is called J&J 3989, which targets 2 RNA trigger points. And the result of this compound was actually recently presented in the European meeting earlier this year. This compound, given at a 3-monthly dose, resulted in profound and sustained surface antigen reduction up to 48 weeks after treatment. For responders, you can see that there's a significant decline, but even for what they termed non-responders, you can still see a significant, albeit less, decline in the surface antigen while on treatment. And you can also appreciate the corresponding decline in hepatitis B RNA, the E antigen, and also with the correlated antigen. And another 2 compounds were also presented in the same EASL meeting earlier this year. One was called VIR-2218. 2 monthly injections of this compound with escalating doses resulted in a dose proportional reduction in surface antigen levels. And this surface antigen reduction was still observed until at least 16 weeks after the last dose was given. And the other new siRNA compound, RG6346, also showed a very promising surface antigen reductive effect with a 4-monthly injection regimen and with a significant reduction in surface antigen level compared to placebo. Remember, oral nucleoside and nucleotide analogs rarely produce surface antigen decline as such. They can cause rapid decline in hepatitis B DNA, but usually they have no effect on, or very little effect on, the surface antigen level. Another potential target for antiviral therapy is the hepatitis B core protein, which is essential for genome packaging. And compounds, these are compounds known as CPAMs, or core protein allosteric modulators, can destabilize the hepatitis B core protein assembly process. And there's essentially 2 groups of CPAMs. Class 1 results in aberrant nucleocapsid formation, whereas class 2 CPAMs results in empty nucleocapsid devoid of any virus genome. In addition, these CPAMs can also inhibit recycling of relaxed circular DNA back into the nucleus, and hence they can actually reduce over time the overall cccDNA pool. And in a phase 1 trial of a compound called NVR3788, and in fact this was the first prototype CPAM, you can actually see a significant reduction in both HBV DNA and HBV RNA in a dose-dependent manner. And this appears to be somewhat augmented when you combine the CPAM with pegylated interferon. And another phase 1 study published earlier this year on another CPAM called Vibacavir, another novel CPAM, again showing significant reduction in Hep B DNA and also Hep B RNA. So the results for novel direct-acting antivirals for hepatitis B appears to be very promising and very well tolerated. So moving away from the DAAs, I will spend the remaining short time focusing on the immunotherapeutic strategies. The chronic infection of hepatitis B virus occurs with underlying persistent hepatitis B specific immunological dysfunction. You get exhaustion of the hepatitis B specific T cells, you get poor cytotoxic activity, and you also get the impaired cytokine production together with high expression of the inhibitory molecules. Therefore, immune restoration may actually potentially lead to a functional cure once the immune deficit is reversed. And there are several ways to do this. You can stimulate the innate system, e.g. by the use of these T-toll-like receptor agonists. You can block the immunosuppressive pathways, or you can encourage production of viral neutralizing antibodies, such as the use of therapeutic vaccines. And I'll provide you with examples of some of these. This diagram shows you the stimulation of the toll-like receptors using TLR agonists, which then leads to activation of these downstream signal pathways, resulting in overall increased production of pro-inflammatory cytokines, chemokines, interferons, which all of these are important in virological control and also in viral clearance. And also, they can also increase and enhance the function of hepatitis B specific T cells, again, hopefully to enhance virological control. An example of a toll-like receptor agonist was presented again in EASL earlier this year using 24 weeks of a compound called selgatolimod in virally suppressed patients. These are patients already on oral nucleoside or nucleotide analogs. And you can see the waterfall plots showing the reduction of surface antigen at week 24, and also the effect was still seen and observed at week 48 while off treatment. And although the decline in surface antigen from baseline was only very modest, they did show that 5% of the treated patients achieved surface antigen loss. Another immunological target is the blockade of immunosuppressive pathways, such as PD-1 and also CTLA-4, which are often upregulated in chronic hepatitis B infection and can be associated with T-cell exhaustion and also with the persistence of chronic viral infection. And in fact, several checkpoint modulators are already approved for use in oncology, including HCC patients, and therefore are readily available to explore in our chronic hepatitis B patients. And these checkpoint inhibitors may actually potentially restore the T-cell dysfunction or exhaustion that sometimes can occur with chronic hepatitis B infection. And in this phase 1 study of nivolumab, with or without therapeutic vaccination, you can see that a slight reduction of surface antigen level was observed. Again, although the reduction appears to be very modest only, you can see there was only one patient, there was at least one patient out of the 22, so roughly around 5% who achieved a functional cure with loss of surface antigen. Now, to achieve a functional cure, the cccDNA inside the nuclei of infected hepatocytes must be targeted. These cccDNA actually forms a very stable pool of template that is pivotal in viral replication and also production of viral proteins. And there are several potential methods to target the cccDNA. Firstly, one can inhibit its formation, which means that everything downstream is also inhibited, including the transcription of hepatitis B virus protein and also with subsequent replication. Other methods include cccDNA silencing. We've seen some examples of this using RNA interference, whereby you can actually cause destruction of the mRNA and subsequent transcription of and translation of virological proteins. And of course, cccDNA can be eliminated using different methods. Again, this will be important in chronic infections whereby there's already an established pool of cccDNA, and you need to actually actively eliminate these active pools. However, at this moment in time, there are actually no drugs targeting cccDNA, and it is unlikely that there will be any in the very near future. Having said that, this table highlights the numerous agents actually going through various stages of clinical development currently, with compounds already, some already in phase 2 trials. So hopefully we will see some of these come through into clinical practice in the not so distant future. And it is likely that these agents, when it comes through, will be used as part of combination therapy, targeting different aspects to achieve a functional cure. An example of this would include the use of agents to inhibit viral replication, like the current nucleoside and nucleotide analogs, to lower the viral antigen burden by the use of siRNA, and also to boost or enhance the host immune response in order to achieve a functional cure. So in summary, oral antiviral therapies alone without hepatitis B immunoglobulin are very effective, highly effective actually, in preventing hepatitis B reactivation after liver transplantation for chronic hepatitis B patients with excellent long-term survival. liver transplantation, remember, is not a cure for a chronic viral infection such as hepatitis B, and therefore lifelong prophylaxis is required. And current oral antiviral therapy is very highly effective in suppressing replication, but not effective in achieving a functional cure in terms of surface antigen loss. However, many upcoming novel agents targeting different parts of the hepatitis B cycle and host immune response are in various stages of clinical trials, and they've antiviral efficacy, proven safety, well tolerated, and are likely to become available in the near future. The functional cure will be likely to be achieved by, as I said, using a combination of different agents, but a whole host of questions still remains, such as the optimal number of agents to use, which combinations you'd be using, the optimal number of dosages of treatment, especially those requiring parenteral treatment, and also the optimal duration of therapy. And finally, complete and sterilizing cure is currently unlikely to be achieved in the very near future. So I thank you very much for your attention, and I look forward to any questions. Thank you.
Thank you so much, Dr. Fang, for that excellent overview. I think that a lot of us initially thought that with the advent of antivirals, hepatitis C would be pretty much a done deal, but as you've shown very convincingly with your data, this is a problem that will bedevil us even after transplantation. So there's one question from the floor from Dr. Harshal Rajekar asking how important is the DNA status at the time of the transplantation?
That's a very good question. And I think back in the days when we first started liver transplant, the level of HBV DNA was actually an important predictor of outcome because they only had HBeC and perhaps lamivudine only. And at the time, a higher DNA at the time may lead to a higher risk of resistance. But nowadays, it is almost, we don't actually look at it as a decision maker. So we don't see it as an important factor. And I've already shown in one of the slides, in fact, that over 75% of our patients, or around 3/4 of our patients, are actually viremic at the time of transplant. And up to about half of them overhead about 4 to 5 logs or over. And again, once you do the transplant, you remove the liver. In fact, you remove the bulk of the virus, including all the cccDNA and all the integrated DNA inside the liver. I'm talking about inside. So you have a massive drop. So whatever happens pre-transplant, 8 or 7 logs, even 6 logs, etc. After transplant, if you do the viral load immediately, you're going to find that it's going to become very low. And if you keep them on antiviral therapy, it's going to gradually fall to become undetectable. So it's not an issue. And I think that's the reason why you can actually see a lot, why there's such a high rate of surface antigen seroclearance after transplant, even without giving them any HBeC at all. Because again, you're removing the bulk of the viral particles, but you're actually not removing everything because you still have extrahepatic sources. They're still in the white cells and the spleen and the kidneys, etc., etc. Yeah. So, but to answer your question about the importance of viral load at the time of transplant, in this day and age, I don't think it is a very important aspect at all.
Rajiv has joined us. I think he's just scrubbed out.
Yeah. Hi, James.
Hello. Thank you for asking me. Nice to see you again. Yes.
Yeah, nice to see you. And I do hope we'll be able to get it down here for one of the next sessions of the Frontiers.
Yes, I'm very much looking forward to it. Actually, yes.
Yeah, I mean, great talk, James. And I know that Queen Mary was one of the first places to use core-positive living donors for transplantation, and you've written numerous papers on their safety. And certainly, we are also turning to using a few selected core-positive donors here. I mean, recently we had a discussion in our MDT listing meeting, about the possibility of considering a surface antigen positive donor.
Yes. Yes.
So, what are the views on that?
Yes. So for core positive, there's actually no issues at all. You already know that. For surface antigen positive donors, in fact, we also have started a protocol to use that. Again, it's only reserved for hepatitis B carriers, so you're not passing a new infection, but they must undergo a very stringent workup beforehand. So they must have a histology, they must have imaging, they must have the alpha fetoprotein, etc., etc. and they must be below a certain age. I think our protocol currently is about the age of 55. And anything above that we try not to use because there may be established fibrosis, even though we may not pick it up. And also after transplantation, of course, these patients are going to be at a higher, well, they're going to be at a lifelong risk of HCC. So irrespective of whatever their initial primary liver disease was, they will need lifelong surveillance for HCC. So it's different with, in a person who has no HCC, so a person who has fulminant hepatitis B or acute flare of hepatitis B, they get transplanted with a normal liver, they're not going to get de novo HCC. But if you transplant a surface antigen positive liver inside that person, that surface antigen positive liver is going to be at risk of developing HCC in the lifelong process, just like any other normal chronic hepatitis B carrier. So that's one key difference. We don't accept, I know Taiwan has done a few studies looking at living donor liver transplantation and using surface antigen positive donors, but that I don't think that is an ethical option at all, because those patients who are actually surface antigen positive, again, they will have a lifelong risk of hepatocellular carcinoma. And if he develops an HCC and he's already undergone a hepatectomy, then the treatment options for that patient is going to be much, much less.
Yeah. Okay. So the message is that, so for a living donor, hepatitis B surface antigen positive living donor is still not ready.
I don't think it's a good idea. Yeah.
Okay. Thanks a lot, James. Thanks.
Thank you.
Thanks a lot, Dr. Fang, for that, for your talk once again. If there are no more questions, we'll move on to the final talk of the evening. That's by Dr. Joy Varghese. Again, somebody who doesn't need any introduction to all of us who work in liver disease in India for sure. He's the director of hepatology and transplant hepatology at Gleneagles Global Hospitals in Chennai. His topic today is liver transplantation for acute or chronic liver failure, grade 2 or 3, science or fiction. And I must say that although we have had 2 talks which have really been on the realm of science fiction, ACLF transplantation often seems to be closer to fiction than science. We look forward to hearing Dr. Joy's views and his discussion. Please do type in your questions as and when they come forward so that we can address them at the end of the talk. Thank you. Joy, just unmute yourself, please. Joy, please unmute yourself.
Yeah. So now it's okay. Sorry. Now it's clear.
Yes, you're audible and the slides are clear. Please carry on.
So thank you, Dr. Sonal and Dr. Charles Penkel for kind invitation. It was really nice and informative talk by the Professor Darius Misa and Professor James. And now the next 10 to 15 minutes, the topic is on liver transplantation for acute and chronic liver failure, whatever the science and function. The terminology ACLF came into our medical history in the year of 2002 by Rajiv Jalan and Roger Williams, very practical. There was a lot of discussion about what about the acute decompensation in the background disease, how to differentiate from ACLF, whether it's a separate entity or not. Now, it has been clearly evidenced, scientifically proven by ACLF individual here associated CIRS component, that CIRS component related decompensation. If you look into the acute decompensation in the background of either chronic liver disease or decompensated chronic liver disease, acute decompensation may be in the form of variceal bleed or sudden onset of ascites or encephalopathy or HR responsibilities. But if you check that particular individual's CIRS component pro-inflammatory markers, it will not be high. At the same time, in the acute and chronic liver failure, even though there will be the acute decompensation but the pro-inflammatory markers level will be high. The marker-related organ failure and the outcome will vary. So now ACLF is a separate entity. What about the outcome of ACLF without liver transplant? So how we are assessing the liver transplant outcome in acute decompensation or end-stage liver disease? Usually whenever the patient comes to our clinic, we will calculate what about the current MELD score. This MELD score will predict the patient's, okay, how sick and how yearly we have to do transplant. But is it the same MELD score? Is it applicable to assess the severity of the acute and chronic liver disease? If you look at this picture, it clearly will show this first one is the acute decompensation in the background of chronic liver disease. But if you see, the MELD score increases, the mortality rate increases. But in case of ACLF, it's a 2-organ or 3-organ failure. Even though MELD score is low, not low, actually I can say it is less than 25, but the mortality rate is high. So this picture very clearly shows MELD score is not the predictor to assess the mortality of the ACLF. Second important message from this picture, 2 or 3 organ failure happens. Whatever the MELD score, the mortality rate is much higher than the acute decompensation of the chronic liver disease. So MELD score is not the predicting marker in ACLF. So what marker we have to use? We can use SOFA score to assess the ACLF grading. And it shows 2 or 3 organ failure. The outcome, if you are not doing liver transplant, the outcome is poor. Among the organ failure, so what is the important key organ is the prime mostly the renal dysfunction. In ACLF, if you ask, this all based on the canoic study, that is the only one prospective study. In 2013, it was conducted for ACLF, and they graded no organ failure versus 1 or more than 1 organ failure. So in the study, it clearly shows out of the all organ failure, renal dysfunction, that is the key. If that organ failure outcome is much worse than the other organ failures, second most organ involvement is the hepatic encephalopathy. So how severe the ACLF 2 or 3 organ failure? If you see this map, you can see, we can understand the waiting list mortality in this is the ACLF 2 organ or 3 organ failure. It is worse than the ALF. That kind of the mortality rate is increasing in the compared with the ALF. But we know ALF outcome is very poor. Whenever we are seeing as a clinician ALF, we will immediately start the workup and we will insist. But if you look into that grade, the 2 or 3 organ ACLF failure, that mortality is much higher than the ALF. So what about the involvement of the cells? Because I earlier told the difference between the acute decompensation in the chronic liver disease versus ACLF with the cells. So what about the cells involvement and the respiratory failure? This picture is the heat map. If you look into here, they mention all the inflammatory markers, most of the inflammatory markers. This is the acute decompensation. This picture is the acute on chronic liver failure. This heat map study shows this. Forget about the respiratory failure. Without the respiratory failure, So this CIRS component is more going into the ACLF. But if you look into that, even though there is no ACLF, if the concerned individual have the respiratory failure, that time the CIRS component is proscribed. This is a new point we have been insisting. Even though they are not a ACLF, if it is acute decompensation, if the concerned individual have the associated ARDS, whatever the reason, that time the inflammatory markers will go back. So what about the outcome based on the ACLF? So we know what is the ACLF, what is the definition, important of the CIRS component, and its mortality, 2 or 3 organ failure is worse than the ALF. And if you this is the 4 organ failure, this also is the ACLF. 3A means 3 organ, 3B 4 organ failure. It shows almost close to 100% mortality. So as a clinician, whenever we are seeing a patient as a first time in our ICU, if it fulfills the ACLF criteria, if a 4 organ failure, it's our duty to tell the almost the mortality will come close to the 90 to 100%. But interestingly, if you look into the 3 organ failure, at the time of diagnosis, it's almost 70% mortality within a 1 month. But if we stabilize the patient in the next 3 to 7 days, we can bring down to 33%. This is almost equal to ACLF 2. This is the important key message in the slide I wish to convey. If you are seeing a patient with ACLF 3, aggressive in therapy, the ICU care we have to provide, we have to identify the restricting factor, we have to support the concern, whichever the organ failed. There is a more possibility within 7 days, we can bring to the almost ACLF 2. So what about the outcome? So now we know the ACLF, the severity, and we know it's our duty, the care, the need of intensive care has been insisted. What about the liver transplant outcome in ACLF? There are so many studies that has been come up in the DDLT setting, in the living donor liver transplant, even from our India. There are publications about the outcome of ACLF in a liver transplant. But I have taken here the large volume studies based on the UNOS database. Here in the ACLF, almost 3,556 transplanted patients, and in same, there is a UNOS database, almost 6,381 transplanted patients. So Paul Kulavath and the Sundaram et al. Study. If you look into that, ACLF, earlier we told, in the ACLF 3 and 2, that without a liver transplant, the outcome will be poor. Here, if you see, almost all total patients are ACLF 3 groups. By doing transplant, the outcome is almost close to 80%. That means if you are doing ALF patients, emergency liver transplant, outcome 75 to 80%. But we know in ACLF 3, it's worse outcome than the ALF without doing liver transplant. By doing transplant, it is almost equal to the ALF transplant outcome. Earlier, that was the database. What are the head-to-head comparison? By doing the liver transplant in ACLF, by doing a liver transplant with the non-ACLF group. If you see, there is no significant p-value difference, either 3 months or 6 months. So from this data, we can come to know, even though ACLF 2 and 3 are poor outcome and we need a good intensive care to support the organ, by doing liver transplant, the outcome is almost equal to non-ACLF group. So this once again insisting in ACLF 2 or 3, by doing early transplant, almost the outcome survival is 80. If we are not doing liver transplant, there is a significant mortality, almost 10%, almost 90% mortality. So how to approach? So already in a slide I told, even if you are seeing a patient with ACLF 4 organ failure, mortality is almost close to 100%. If you are seeing a 3 organ failure, it's our duty to support the thing, and it is possible to bring into the 2 organ failure. So if you are seeing the ACLF, we have to see whether it's any contraindication for liver transplants there or not. That time we can easily omit. If there is no contraindication, here it is the alcohol. But in our LDLT, even in our data, we are seeing most of the precipitating factor in ACLF is the ethanol ingestion. Most of the patients will come with the acute ingestion and going for the ACLF. So that time the 6-month abstinence is difficult. But if it is there, then we need a special program they mentioned. It needs the counseling, and we have to know whether the patient is totally addicted to alcohol or not. If the concerned individual is totally addicted to alcohol, we should not suggest the liver transplant. And we have to assess the grade. If it is the ACLF grade 1 organ failure, even though it is the renal failure, so it's almost equal, so because we can manage easily. If it's a 2 or 3 organ failure, we have to suggest the emergency liver transplant equal to the ALF case. And at that time, we need the bridging supportive therapy. We have to support the organ with in our intensive care unit. If the CLIF score, the SOFA score shows more than 64, or if the patient has ARDS, uncontrolled infection, or the cardiogenic shock, refractory shock, or bleeding, not the varicose bleeding, due to the severe coagulopathy-related excessive bleeding from everywhere, that then we have to support bridge therapy on all the care. In case it improves, then immediately it all happen within few days. Within the few days, we have to take the case for transplant. If there is no improvement, the score is more than 64, that time we have to no transplant. We have to accept the poor outcome. So before to conclude the talk, this is our own data about because I told that supportive care in a tertiary care unit in ACLF, at present we have the supportive tool in India is the therapeutic plasma exchange. So this it's under publication. So now these are various diseases. Now we will take in our center study on ACLF alone. So not the ALF or other polycystic liver disease. So in our ACLF group, so totally 68 patients. So grade 1, there is 1 organ failure was 29, 2 organ failure 18, and the 3 organ failure was 21 patients. So the etiology of the acute episode was, most common etiology was ethanol ingestion, second sepsis, third drug induced, fourth was the hepatitis B virus reactivation. And the background etiology, again, there is most of our patients have the alcohol induced, ethanol related, and the second most will be NASH related, third the B virus. Out of the 68 patients, because this not for transplant related the study, so we supported the patient with all routine standard, along with the standard therapy, liver supportive care. We subjected the person to the plasma exchange. So here the definition for survival, how many of the patient got discharged from the day of the first admission. So in our ACLF group, 60% of patient discharged, almost close to 12% of the person underwent transplant, remaining close to 30% of the individual though they underwent therapeutic plasma exchange, but the outcome was bad. So here in our study, ACLF group, therapeutic plasma exchange definitely will be the role in the 2 and the 3, not in grade 1 organ failure, because most of the time one organ failure is the renal dysfunction. The 2 and the 3, that time it acts as a bridging therapy. So thank you so much for listening. If there is any questions, I'm happy to answer.
Thank you, Dr. Joy, for summing up such a complex topic and certainly adding a very intriguing aspect of adequate critical care optimization of these patients. So while people are collecting their thoughts, my first question probably is related to the fact that most of the patients who we see with ACLF come with an alcoholic etiology. So you've talked about decreasing the stage of ACLF, and we know that a lot of people with alcoholic hepatitis on top of a CLD will automatically improve. So do you think that this kind of downstaging of the ACLF 3 to 2 is possible in non-alcoholic etiologies, or is there a sort of built-in advantage in the alcoholics? Because anyway, you will expect the inflammation to come down once the alcohol is sort of removed, from the equation. Am I clear? I mean, do you see the same downstaging in non-alcoholic etiologies?
Yes.
Yeah.
So and I can answer in a different way for the ethanol. One is the acute decompensation in chronic liver disease. For example, a chronic liver disease due to ethanol individual, they will take a pinch of alcohol. They will present to our OP with high bilirubin and a mild altered coagulopathy. So we will put ACLF. But if you look into that, their inflammatory markers and their organ failure, associated organ failure will be less. So that is the case. It's not a ACLF. That is an acute decompensation, just the elevation of the jaundice. And if there is no associated organ failure, we should not put, that is the case of ACLF. We have to write it out, severe alcoholic hepatitis. So that group is different. And if the same individual, after the pinch of alcohol, due to the inflammation, cyst activation, if they come with a mild renal dysfunction and that related coagulopathy or sepsis, mild sepsis related altered sensorium, that will come with the, mostly what we have done, the PPE in that group is that is a typical, as they have associated other organ dysfunction, non-liver organ dysfunction, with there is a rise in the inflammatory markers. If you look into that non-alcoholic group, mostly non-alcoholic individual decompensation, acute decompensation, we can say mostly portal hypertension related decompensation.
Okay.
Either the variceal bleed. That variceal bleed will cause hypotension, cardiac failure, the cardiac support. The variceal bleed will increase the ammonia level. That will go to the encephalopathy. So, simple GA bleed, it is causing decompensation in the form of 2 organ failure, heart plus encephalopathy. But if you intervene, so the GA bleed by endoscopically, we are able to identify banding and hypotension, there will be quick recovery. If that time, if you look into that, all the pro-inflammatory markers will not be high. Okay. So that's why earlier, which was thought all are one group, now it's very clear, even though there is a 2 organ failure due to the variceal bleed, but it is easily manageable, the patient will come out. That time we no need to write in our case sheet, it is a ACLF. Other group is there is a FILD, NASH-related cirrhosis, but they are getting sepsis or drug, any hepatotoxic drug, or they are getting a cellulitis. That cellulitis is causing the mild coagulopathy, mild renal dysfunction, even though there is no encephalopathy, that will cause the ACLF definitely. So mostly in a NAFLD group, ACLF, the precipitating event, more it will be the sepsis, either the cellulitis or SBP or UTI or the respiratory infection. That will play a major role.
Okay, right. So basically what you're saying is that the precipitating event is basically what decides whether or not a downstaging would be effective as opposed to the etiology per se. That is the is that the message?
Yeah, most of the time we can identify the precipitating event either in acute decompensation or in ACLF.
Sure.
But it is sometimes it's a very difficult to identify the precipitating event in ACLF. But that time we have to go for aggressive organ support. Which organ failed? If the renal dysfunction, renal supportive care. If they're the respiratory support. So if they're cardiac, hypotension. So we should not delay in that. If there is a delay, then it will go to the outcome in the board.
Correct. So there's a question from the floor from Dr. Parekh. When do you decide for TPE? Any objective criteria?
Yeah. So this at present there is no, only one prospective study has come out in the ACLF, and that they have mentioned the hepatitis B from the China, the paper, the HPV related reactivations. So that time, what about the role of TPE? It shows it's helping as a bridge therapy. But another one, the lot of the, not a RCT trial. So there are the cohorts level, they control, they come comparing with the historic control, there are papers. That time, TPE nowadays is access a bridge therapy. Normally, if there is a 2 or more than 2 organ failure, that time TPE will play a role. If the patient's on a DDLT waiting list, we have to do, there is a possibility patient will get discharged. That's why in our paper we are coming to, we are going to publish that. If the patient is an LDLT setting, of course, if the patient is stable, then we can do the contraindication for TPE. If the patient have inotrope support or the patient have associated sepsis or septic shock, from that time we should not go ahead for TPE. That is the way. So indication, grade 2 and more than 3, 2 or 3 organ failure. Contraindication, either suspected sepsis or proven sepsis. That time we should not subject our patient into the TPE.
Okay.
Next up, Joy, Charles here.
Charles, yeah.
Hi, Joy. What would be the volume of TPE when you do a TPE for ACLF? What would be the volume that you target, and how frequent would you do it, and how many sessions would you give them?
Yeah. So if the paper, whatever the RCT trial published by Professor Julia Wendel from UK, they are using the high plasma volume. They are using 1.5 plasma volume. And here we are using 1 plasma volume. So this automatically the machine will calculate based on the patient's hematocrit value and their age, and it will calculate how much the plasma the concerned individual have. In the 1 plasma volume, what we are doing in our center, if the patient have, will get the 50% replacement by fresh frozen plasma, 25% by the 5% human albumin, and remaining 25% by the normal saline. If the concerned patient have the severe coagulopathy, that time 75% of the plasma volume, 1 plasma volume replacement will be fresh frozen plasma. In simple way, I can explain, if the patient have only severe cholestasis, not much severe coagulopathy, that time we can reduce the plasma component, FOP component, we can give more of 5% albumin with normal saline. if our patient has a severe coagulopathy, but severe cholestasis, that time we can use more of FFP component rather than the 5% albumin or normal saline. Normally, we are using one plasma volume replacement.
Yeah, thank you, Jai. And how frequently you to do it? Daily, alternate day,
Yeah.
and how many sessions would you give before you?
So this is a good question, because if you are subjecting a patient today with a therapeutic plasma exchange, 24 hours later, we can check their parameters, liver function test associated with the ammonia. In case, even after the one plasma exchange, if there is no significant improvement in the liver function test or the prothrombin, it will indicate the patient's liver is too bad. So even if you are subjecting the individual second or third, the outcome will be poor. Outcome in the sense they will not get much benefit. So it is giving slightly prognosticate. We can tell to the family member the concerned individual is almost the failed liver, need very emergency liver transplant. In other way, if there is an improvement, there is a fall in the bilirubin level, improvement in the iron or coagulopathy level, that time in 24 hours later, no need to wait for 2-3 days, because if you go through the graph of the plasma exchange related that outcome, the benefit, if you are doing the plasma exchange periodically, regularly, that time the clearance level rate will be very high. So we have to subject for the second plasma exchange. 24 hours later, we have to check again. Most of the persons, those who have the first time shows improvement, second, third, normally the plasma exchange wise, we can bring down close to 10 bilirubin, not less than 10 in the ACL setting. It is our experience. It is not going less than 10, it's coming close to 10. Even though bilirubin is 30 plus, we can bring down by the thing. So only thing we have to look into that, most of the individual will get either hypocalcemia or hypokalemia or some allergic reactions or the chest congestion or the hypotension. That all we have to control. That time, more if they are not tolerating even with the first cycle of the plasma exchange, we should not suggest to that. So one is the patient's tolerance. Second, if there is no improvement with even first cycle, it will not showing much improvement in the subsequent cycle.
Thank you, Joy. And again, I mean, just a quick question here, because you obviously do both a living and a deceased donor program, like most programs in South India. So where is your sort of cutoff, your threshold for cutoff, where you would say perhaps you don't want to do a living donor transplant at all? Is it ACLF3, for example? Or would you say that you would downstage to ACLF2 and then consider for a living donor transplant?
If that's
as opposed to living versus deceased donor is the question.
So the deceased donor, almost, I mean, when we get the organ, no one knows. So that time when we are getting the organ, if it is the marginal liver and the patient is already too critical, so mostly we won't allocate the organ to the sick patients. It will go to the whoever the stable patient. If it is the good quality organ, if you are getting, that time, that point, the particular point, the SOFA score assessment wise is less than 64. That time we can suggest, we can go ahead for the transplant, because as I already mentioned, by not doing transplant, that is a 10% only the survival, almost 90% mortality. So by doing transplants are good. In the living donor transplant, that is the scenario is different, because we will evaluate meantime that we can keep the donor stable. I mean, evaluate everything, documentation, approval, committee approval, everything, we'll keep it ready. Whichever the day, the patient is good. But what we are facing nowadays, sometimes even though donor is available, financially they are okay, committee gets clearance, the patient will not improve. And at that time, we will tell the patient already is going from ACLF, that 3 organ failure to 4 organ failure. So we will say he is not a suitable. We can wait for another 12 hours. That's a routine thing we are using the word. We'll wait for next 12 hours with all the supportive care. Whether there is any improvement, we will take. So most of the time, we can see as patient's deterioration.
Thanks a lot, Joy, for that. There have been 125 people who logged in to watch this session, which is obviously reflective of the interest that all our speakers have sort of aroused in sort of the participants. I'd like to hand this over at this point to my colleague, Dr. Karthik Raichurkar, for a closing summary and a vote of thanks.
Thank you, Dr. Sonal. I thank the organizers of FILD for the opportunity to talk. Starting with Dr. Darrell's talk, he talked about patients with ALF in infants with size being less than 5 kgs. He took us into the surgical aspects, the techniques, the need for bloodless surgery, the need for minimizing the anhepatic phase, the fine sutures that needs to be used, and the clamps that need to be used to prevent crushing in the portal vein. The problems were well discussed in the form of large for size syndrome, the need for abdominal wall reconstruction, and trying to delay it if the graft is too large. Various variables contributing to mortality like creatinine, INR, and donor age were discussed by him. And he did show that if it is recognized timely and the correct selection is done with ruling out contraindications in the form of mitochondrial disorders, and good technique is followed along with the availability of good pediatric anesthesia and critical care facilities, then the results of acute liver failure in infants is very much comparable to what happens in bigger children. Next, summarizing Dr. James' talk of precision medicine in hepatitis B. He started the talk with how hepatitis B is increasingly coming in older age individuals, higher incidence of HCC and less of them presenting with decompensation now, and how with the available medicines, viral suppression is possible and sterilizing cure is still a distant dream. And with the decreasing use of Hep B immunoglobulins, how transplants are being done. He talked about the cascading cure, right from viral suppression to the sterilizing cure. All entry points for the virus, the viral entry inhibitors in the form of cyclosporin, interference of mRNA activities with use of small interference RNAs, the inhibition of nucleocapsid formation with core protein allosteric modulators, immune inhibitor pathways using nivolumab. All these things were discussed, and he did conclude that at this point of time, possibly sterilizing cure is not possible, and a combination of all these different agents could be used in the future to be able to achieve a sterilizing cure. Coming to Dr. Joy's talk, it was an excellent talk on acute on chronic liver failure. He stressed on the importance of differentiation of acute decompensation versus acute on chronic liver failure, which has a cells component contributing to higher mortality, and med scores being not indicators of mortality, and organ failure with the use of CLIP SCOPA scores is more important to achieve the predictor of mortalities. He stressed on the importance of how grade 2 and grade 3A ACLF patients need to be treated and stabilized before pushing on the path towards expeditious transplant. And when CLIP SCOPA scores of more than 64 with 4 organ failures were there, and we are not able to stabilize the patient, and we need to explain futility of care to these patients. He did summarize and ended the talk with the role of plasma exchange, showing his data on good survival. So these are about the talks today. So all the talks I believe were very good and informative, and we thank all the speakers on behalf of FILD for the excellent talk. Thank you. Thank you one and all.
Thank you. Thank you. Thank you, Joy.
Thank you. Thank you so much. Thank you, Sonal. Thank you, Charles.
Thank you.
Bye all. Thanks very much, and all the best, guys.
Thank you, Prof. Thank you. Thanks for the talk. Excellent talk.
Thank you.
Thanks, Professor. Thanks, Joy. And thanks, James.
Thank you all, and have a good evening from Hong Kong. And thank you for having me.
Good night.
Thank you, Prof.
Good night.
Good night. Good night.
Okay,
Thank you.
good night.
Good night.
Good.